Okay, so good morning everyone. Promise it's not going to be as dull as the title slide. My name is Roisin Morgan, I'm Irish. Moved from Ireland to Boston almost 3 years ago to work at the Brigham. You'll see that in a few slides. And then I moved up to Maine last summer and I'm a cardiologist at Maine General, both in Augusta and Waterville, and I also do some work at Maine Med. So I'm kind of working in a few different places. So when I got the email about this talk, I believe that in previous years there have been some very interesting people talking about some very interesting things. The only thing that I have that's interesting, I suppose, is that I'm Irish and I have an accent. My name is kind of funny, but I'm going to take you through where I've come from when I was, your age, basically how I got to where I am now, and then I'm going to show you some really cool cases from when I worked at the Brigham. So, is this working? Okay, it might not be working.
The arrow, so try to get it to.
Yeah.
I have.
Let me see. Oh, maybe I haven't pressed play yet. Here we go. Okay, I'll just do this. So I have no disclosures for this talk. So my first slide, this is, I don't know if anyone's ever been to Ireland, but Ireland is a small little country on the west of Europe, and you can actually, if you picked Ireland up and put it into the state of Maine, it would fit. That's how small it is. And basically Dublin is the capital city. I'm from this little county called County Louth. It's broken up into all these little areas called counties. Most of you probably know that there's the north of Ireland and the south of Ireland. The north of Ireland is part of the UK, the south of Ireland is the Republic. And basically it's a beautiful country. It's very green, it rains all the time. We have beautiful rivers and lakes and lots of history, and it's a fantastic place to visit if you ever get a chance. Hopefully, if you do get a chance, you'll be lucky enough to be there when it's sunny, when it's beautiful, because when it rains, it's just kind of cloudy and dull. But at least we don't get snow, but we don't get hot summers either. So it's kind of like spring all year round. So basically, in Ireland, to go to medical school, you go straight from high school. So I left high school at 17 and I went straight to university. I went to UCD. University College Dublin was the campus, and medical school is 6 years, and so you do, the first year is all science, the 4 sciences, biology, physics, chemistry, and must have been a fourth one. I think we did histology in first year, and then from second year you go on to do your anatomy, your physiology, your histology, your pathology, and then the clinical years start to come in around the 4th year. And then 4, 5, and 6, you rotate through the different hospitals and do all the different specialties. And so at the end of 6 years, you graduate, hopefully, and then you do your intern year. So I did my internship in the Mater Hospital in Dublin, and that was 1 year. So the first 6 months of that was medicine, and the second 6 months was surgery. And then you decide whether you want to be a medic or you want to be a surgeon. And most people kind of know before they get to that point, but those months definitely help you to decide. So I decided to do medicine, and then I moved from there to St. James's Hospital, which is also in Dublin, to do a 2-year medical residency. And basically you rotate every 3 months through different specialties like cardiology, rheumatology, gastroenterology. So you can kind of pick which ones you want to do, and you go through them over 2 years. And at the end of that, then most people had an idea as to what they wanted to do. So a lot of people go into GP or general practitioner, family doctor. Those that stay in hospital medicine decide, do I want to do cardiology or GI, or what do I want to do? So I wanted to do cardiology, so I applied for the cardiology fellowship. So most of the training in Ireland is run by what's called the Royal College of Physicians of Ireland, which is our training body. And the cardiology fellowship program is 6 years. So that's 6 years of, and that's 6 individual years. So you do 1 year in one hospital, 1 year in another hospital, and you move around the country and get lots of experience in that 6 years. And then at the end of that, most people then either do what we call an MD or a master's degree. It's a 2 years full-time research degree, or a PhD, which is 3 to 4 years. So I did a master's degree at Trinity. So Trinity College in Dublin, and so I did that full-time research for 2 years, and I did that on microcosting. So basically the Irish healthcare system is different than over here. It's what we call a public system. It's paid for by the taxpayer. And so every single person in Ireland is entitled to free healthcare. If you walk in off the street, you're entitled to be treated and you won't get a big bill at the end of it, which has pros and cons. Obviously, it's great for those people that can't afford healthcare and can't afford health insurance. But the bad thing about it is that if you need to get elective surgery done, the wait times are long because the demand exceeds the doctors and the nurses, and the supply is just not there for the demand. So so I'll talk about that again in a second. So after that, I then went to the Brigham in Boston, and I did a 2-year fellowship in advanced cardiac imaging. And so the 2 cases that I'm going to show you are from there, and they're really cool cases. And then after that, I moved to Maine last summer, and now I work at Maine General. So that's basically how I got here. So just in summary, so basically from the start of medical school to when you finish is 19 years of training, which is obviously a very long time, but I got there. And that's just for cardiology. If you wanted to do general practitioner, you would basically cut out all of this and you do a 4-year GP training. Surgery can be even longer than this. Most of the specialties will be similar, can take you 17 to 19 years. So it's a long time. I was just saying earlier that when I was up here, before I started, my GP at home tried to talk me out of doing medical school, and I didn't listen to him. And if you'd asked me along the way, certainly when I was in medical school, I loved it. When I was an intern and a resident, loved it. Fellowship is kind of where it started to get hard because I was working probably 80 to 100 hours a week, doing a lot of call, and it's very busy. But when you look back on it, you kind of realize how much you learned from it, and how much stronger it makes you. Like when you go into work on a Saturday morning and you leave on Monday evening at 5 o'clock, having been there the whole time, and you're exhausted. Those weekends make you a stronger person, but certainly are not healthy. So as I was saying, the Irish healthcare system is a 2-tier system, public and private. The public system, great for people who can't pay, but not great if you need just elective hip surgery, which the wait time is about 2 years. Private health insurance, then about 30% of the population take out private health insurance so that if they need something elective done, they can get it done quickly, basically, and so they pay for that themselves. Our spending is actually slightly more than the EU average. So it's not that we're not spending the money on our patients. It's just every year the government allocates a budget to the health system, and every year they exceed that budget. And in 2007, 2008, when there was the big economic collapse and Ireland was basically bankrupt and had to be bailed out, some of the conditions of the bailout were that they had to come in and cut the wages of all of the healthcare workers. So all of the nurses, the physios, the OTs, everybody's paid by the state. So they just came in and cut everybody's wages, increased everybody's taxes. So people have been working really hard to make up the deficit that was formed by those years when certain people bankrupt our country. But anyway, they're getting better. So all medical students, all interns, residents and fellows train in what we call teaching hospitals, which are attached to universities, and these are all public hospitals. So you don't train in any of the private hospitals, you train in the public hospitals. And as I said, it's governed by the Royal College of Physicians, and then once you're qualified, we have a medical council that'll make sure everybody's doing what they should be doing. So basically, now I'm going to switch tack a little bit and talk about cardiac imaging. And that's what I spent the 2 years at the Brigham doing, which was a fantastic experience. I don't know if any of you have ever been down there or been to the hospital, but it's in the Longwood medical area. So you've got the Brigham, you've got Dana-Farber Cancer Institute, you've got Children's Hospital, you've got Beth Israel, and they're all in the same area, and there's just nothing but doctors and nurses and patients, and it's a fantastic place, and patients fly in from all over the country to be treated there, and so you see some really, really amazing cases from the point of view of a physician, but obviously difficult for the patient. So I'm going to take you through a couple of cases. The first case is of a 36-year-old man, and he had Hodgkin's lymphoma when he was younger, when he was 15, so he had a large mass in his chest, and the treatment for that involves radiation and chemotherapy. So he got what's called mantle radiation, which is basically where they radiate the whole front of the chest, and obviously the heart's in the middle, so the heart gets involved in that. And he also got some chemo, which is standard, and the type of chemo that he got was called anthracycline-based, and anthracyclines are fantastic for treating the lymphoma, but they're not great for the heart. So he's a few years later going to develop some complications that we'll talk about. So he was cured, and for 21 years he was doing fine. And because he had had radiation and chemo, about every 5 years we screen these patients to make sure that they're not developing any complications from their heart. So he came in just for a stress echo. And so stress echo, basically, I'll talk about the stress part first. The stress test, patient walks on the treadmill. They have somebody monitoring their blood pressure, their heart rate, their EKG. We look at the ECG is recorded the whole way through exercise. And you have them walk on the treadmill that gets faster and steeper for anything from, as long as they can, obviously, but you want them to get to a good 8 to 10 minutes of exercise. And you have what's called a target heart rate, which is 220 minus their age. And so you want them to get to their target heart rate, or almost to their target heart rate, which puts the heart under adequate stress to make sure that its blood flow is okay. And so that's the stress portion. And then we have the echo portion. And so echo is ultrasound. And so basically the sonographer has a probe that they put on your chest, and the ultrasound waves come from the probe into the chest. They meet the heart, and it's the reflection from the heart that comes back through the probe into the machine that generates the image. And so the patient has an echo done before they exercise and immediately after they exercise, and we compare the two images to see does the heart, the muscle should increase contractility, and all the muscle areas should move the same, basically. If any area is not moving as it should, then you'll be worried about the blood supply to the heart. So he came in for his stress echo, and these were just the baseline pictures. So he hadn't got on the treadmill yet. He wasn't even hooked up. So just to orient you a little bit, so an echo, the ultrasound probe is here. This is the front of the chest wall, and the right ventricle, you may have learned about this in your anatomy, is right at the front. So you see the right ventricle first, and then this is the septum, which is the wall between the right ventricle and the left ventricle. And then you see the left ventricle here, the main pumping chamber of the heart. And this here is your aortic outflow, so where the blood comes out every time the heart beats. And back here you've got your left atrium. And down here we've got these colors are basically what we call a color Doppler. And this is a technique that we use to measure the velocity or the speed of the blood flow. And so basically we use color Doppler to see if there's any narrowing or leaking of the heart valves, basically. And I don't know if you can appreciate, if you're not used to looking at normal echoes, but there's something flopping in and out here that shouldn't be there, and it's quite big. And on this one, this is a short axis view where they just turn the probe a little bit and they see the heart's in circles. This is the left ventricle, and it's as if they're cutting the heart in slices and you're looking at it, I guess like an orange or grapefruit. And so the heart muscle is contracting fine all the way around, but in the middle you've got the mitral valve here, and there's something flopping in and out through it, this big mass, which should not be there. Okay. So the sonographer who was taking these pictures was not expecting this, and rightly did not put the patient on the treadmill and called one of the doctors to come in. These are just some more views of this mass. You can probably appreciate it better on this one called a 4-chamber view. We take this from, remove the probe down to the apex of the heart. And so this is the left ventricle, left atrium, right ventricle, right atrium, mitral valve. So you've got this large mass that's attached to the interatrial septum, and it's prolapsing through that valve every time the heart beats. This view here is a subcostal view. They move the probe down to the belly and look up the heart from underneath. These are standard views that are done in every echo usually to look at the heart muscle and the valves, but in this case to look at this mass. And down here we have what's called M-mode Doppler, which basically they put this M-mode Doppler line through the heart, and everything that this line meets should generate a line down here. So your right ventricular wall, your septum, your valve. So these are the mitral valve leaflets opening and closing, but in this case you can see the mass prolapsing through in the middle of these leaflets opening and closing. So just to look at, so when we saw this, we were like, wow, when did this develop? This patient is completely asymptomatic, he's young. Let's look back at his previous echo, which was from 4 years previously. And you can clearly see here, this is what a normal echo looks like. There's nothing in his left atrium, no mass prolapsing through. You can clearly see here that in the last 4 years the mass has developed attached to a septum. Definitely it was not there on the previous echo. So at this point then we started to ask the patient some questions. So he said he had no chest pain, no shortness of breath, he hadn't blacked out, he hadn't had any palpitations, he had some abdominal pain, and he'd been taking a proton pump inhibitor for that just to reduce the acid. But he had some night sweats, which in a patient with previous lymphoma is kind of concerning, and he'd had some shingles, which may or may not have been related. When we're taking a history, I don't know if you've gone through this before, but we always start with the presenting complaint, which is what we just talked about, and then we talk about the past history, so past medical history, medications, family history. So his past medical history, apart from the lymphoma, he had some thyroid issues, he had some lung nodules, and they presumed they were secondary to the chemo that he'd gotten. He had some asthma, and he'd had this benign nerve sheath myxoma removed a few years previously, which again could have been related or unrelated to this. Not on very much for medications, just something for his stomach. Allergies there, but not really relevant to this. And then we always include a social history as part of our history, and just to find out a little bit about the patient, about their home life, about their family, and a social history is really important because it helps you to connect with the patient, so that the next time they come back, you can say, oh, how's your wife, or how are your kids, or it makes them feel a little bit relaxed, and also it's important because then you know what's going on at home in their lives. So he didn't drink and he didn't smoke. Family history, he had a strong family history of cancer. His mother had breast cancer, paternal grandmother had melanoma, his uncle had renal cell carcinoma. And then at the end of our history, we do what's called a review of systems, where we go through every single system and we ask a bunch of questions just to make sure there's nothing else that they haven't told us that might be relevant. So there was nothing in that was relevant. So then we examined the patient, and his blood pressure was normal, his heart rate was normal, his respiratory rate was normal, nothing in his head and neck exam, that was all fine. His lungs sounded clear, his heart sounds were normal, but when we listened with the stethoscope, there's a classic finding that you find with this large mass that's prolapsing through the mitral valve, and it's called a tumor plop. And basically, if you can imagine that mass, every time it goes through the valve and comes back in, it makes this plopping sound. That's very classical for the diagnosis that he had, and you hear it over here at the apex. His tummy was soft, there were no masses there, and he had no issues with his lower limbs. So at this point we knew he had a very abnormal echo. His examination was okay, apart from this sound that we've heard. We got some bloods just to see how things were looking. And so his hemoglobin was low, he was anemic. His iron was low, his iron binding capacity was low. His ferritin was high. Ferritin's kind of a non-specific marker, it can be high for a bunch of reasons, but certainly there was something going on with this gentleman. His kidney function was normal, and his ECG was normal. Okay, so at this point, we have this patient who walked in off the street for just a routine stress echo, and he has this very abnormal ultrasound. And he's starting to get a little bit suspicious now because we haven't put him on the treadmill. And so, at this point, we got his oncologist involved and his cardio-oncologist. And so they, obviously told him the results and said we need to do some further investigations. So he was admitted to the hospital. And when you have a mass in your heart, we have our suspicions from the imaging, but you can't know whether it's benign or malignant until you take some tissue. And the only way to go in and take tissue is basically to bring the patient to the OR, to open the chest, to put the heart on bypass, and to take it out. They take some tissue at the start of that and analyze it and see if it's benign or malignant. Basically that's the only way, because the heart's a moving structure. It's very difficult to stick a needle in from outside the chest into the heart and get tissue and not kill the patient. So in workup for that surgery, he had to have a number of tests. So one of them was what's called a coronary angiogram or a cardiac cath. You've probably heard of some of these things. So a Cath Lab is a cool place. I've been in a lot of them for hours. So basically everything has to be sterile, and the patient lies on this table, and this is the X-ray machine, and these are the monitors. And so once the patient's on the table and everything's sterile, the camera comes in and it moves around the patient and takes X-ray images of the heart and the heart blood supply from different angles. And so you have the operator, usually you have two operators. The main operator is up here and gets access to the circulation and injects the dye. And then you have a second operator for assisting and for handing you things that you need. And this here is the catheter so basically we used to go in through the femoral artery, through the groin in every patient, and we still do sometimes, but nowadays we do a lot through the radial artery, and you put a little sheath in that stays there, and then through the sheath you can pass little wires, and the wires go up the arm to the heart, or else up the leg to the heart, and over the wire you pass a little catheter that goes and sits up there, and then through the catheter you inject a dye and you take some pictures. And the pictures that you get look like this. So this is the catheter sitting in the right coronary artery, and this is the dye that we inject. And so the dye comes down the coronary artery, and if it's wide open like this man's is, there shouldn't be any narrowing or blockage there. So that's a normal right coronary artery. You can probably make out the shape of the heart beating in the background. That's the spine there, that's the diaphragm. Over here you've got the left coronary artery, so the catheter is coming in, sitting on the left main, the LED going down the front, circumflex coming around the side. So his coronary arteries are normal, there's no concern. The surgeon basically wants to know, when I open up his chest, do I need to also do a bypass? But thankfully in this case he did not need a bypass. So the next test that he had then was a CAT scan of his heart, a CT. And there's a few different reasons why we do this. Because he had had chest radiation, one of the side effects of that is that you can get calcification or hardening of the aorta. So the surgeon wants to know that there's no hardening of the aorta before he opens the chest and clamps the aorta. So we put the patient in through the scanner, and CT is fantastic. The patients don't really get claustrophobic. They do have to get dye, so if there's an allergy to dye, then that can be an issue. But in general, for most patients, it's a great test. And it only takes maybe 3 minutes to acquire all the images, and the images are amazing. You can do these amazing 3D reconstructions. We can sit at workstations afterwards and reconstruct the most amazing pictures of the heart, of the coronaries, of the aorta, and the information that we get from this test is just amazing. So this was his CT, and so when we're doing CT, we basically get slices of the chest. We get slices as if you can imagine, if somebody has a sword and slices the chest this way, so we get these slices here, if you do that, or if you use your sword and slice down the middle, you get these sagittal slices. So on this one, you've got the front of the chest along here, and you've got the back here, and this is the heart in the middle. On this one, this is the front of the chest, this is the back, this is the heart. This is a reconstruction that we did. You can see this big, huge mass in the heart that obviously needed to come out. Here you can kind of see it a little bit as well, but this is just really to show you the different ways that we can manipulate this data, and we can create these 3D reconstructions, which are just really cool. After that, he had another test. He had a cardiac MRI, probably because he was at the Brigham and we have access to all of these amazing scans. I'm not sure he would have had all of these done at every centre, but so when you go into an MRI scanner, an MRI, it's a big magnet, basically. So when I don't know if you've ever been in a hospital where there's an MRI scanner, but when you're working around MRI, you cannot walk into the room where the magnet is with any metal on you, because it'll just fly into the magnet. And so magnets have been broken and thousands of millions of dollars of damage done by, cleaners not knowing that they couldn't go in there with the buffer for the floor, and then the buffer gets flown up and sticks to the magnet. So everybody's really careful around magnets and make sure that there's no metal let into the room. And they have special, they have to screen every patient. They have special trolleys or, beds to bring the patient in. Everything has to be specially done so that it doesn't fly up and stick to the magnet. So basically, and when the patient goes into the scanner, you put this coil on their chest, and how it works is that your body is made up of protons and neutrons, and the magnetic field generated by a magnet makes the protons and neutrons move in such a certain way that a signal is generated, and the signal comes back and is analysed, and there's some very complicated physics involved, but basically we get a very beautiful picture of the heart through some complicated physics, and it generates some very nice pictures. So on this slide, hopefully they'll play. They're just loading. It's deciding whether it wants to play or not. Okay. So similarly, this is a sagittal view, so this is the front of the chest. Oh. Go back. Front of the chest, the spine, this is the heart from the side, the left atrium, the left ventricle. It's not playing, unfortunately, but you would have seen this at the mass, like on the other images, was basically prolapsing from the atrium into the ventricle. It's a large mass that you can see here, and you can again see it here. And this one here is what we call a perfusion sequence, where we give a dye to the patient, and you'll see the heart light up bright because the dye is bright. And you want to see if the mass takes it up or not. So if the mass is malignant, there will be lots of little vessels in it, so it'll take up the dye. And if it's a benign mass, it won't. So this mass did not take up the dye, which was good, which meant that it was benign. So after we give the dye, which is called gadolinium, 10 minutes later we do what are called late gadolinium images. And basically normal heart muscle should take up the gadolinium and turn black. And then the gadolinium gets washed out. And if there's any concern about scar or previous heart attack or inflammation or infection, you'll see little white patches in the heart muscle. And similarly with the mass case, we give the gadolinium to see how the mass takes it up, and certain patterns of how the dye is taken up can fit with certain types of masses. So all of this is just about gathering more information to try and give the surgeon the best idea as to what we think this mass is before they take the patient to the OR. So at this point, the patient had lots of beautiful imaging done, and the diagnosis was that he had this large left atrial mass, probably a myxoma, which is a benign left atrial mass, and possibly radiation induced. We didn't really know, but that was kind of everyone's thinking. So he was taken to the OR, and the myxoma was basically attached to the base of the fossa ovalis, which is on the septum between the two atria, and they excised the whole myxoma, and then the hole that was left in the septum was closed with a little patch. And this is some pathology from what they took out, and basically they described it as a friable, tan, nodular, gelatinous mass. It measured 5.4 by 4.2 by 2.5 centimeters, and here it looks, it's kind of all broken up, but it was this large mass. And when they put it under the microscope, they basically found these classic features of a myxoma, which this image demonstrates, to basically confirm the diagnosis. So we pretty much were 99% sure before he went to the OR that this was a myxoma, and then thankfully it was, and that was it was removed, and he did great. So that was the first case. The second case is a similar type patient, so 57. He also had lymphoma, non-Hodgkin's lymphoma, and he had a chest mass in 1981. And he was also treated with radiation and chemo, and he responded well and was cured. So then years later, when he was 42, he had a myocardial infarction or heart attack, and he had to have his LAD stented. So the LAD is the left anterior descending artery. It's the one that comes down the front wall of the heart. And if you think about it, if you attack the heart with a bunch of radiation beams going into the chest, look how close the coronary arteries sit right on the surface of the heart. So they're right there in that radiation beam. And your aortic valve sits right here. That's also right there where the radiation can get it. So it's quite common for these patients to develop coronary artery problems and valvular problems years later. So 42 is young to have an MI in somebody who didn't really have many other risk factors. So certainly the thinking was that this was radiation induced in his case. 3 months later, his stent blocked, so they had to go in and reopen it. And when they were trying to reopen it, they jailed or blocked one of the side branches. So he ended up going to the OR for an emergency bypass. And while they had his chest open, they looked at his aortic valve and thought, God, this valve looks pretty thick and calcified, and he's going to need this fixed in the next few years, so we'll do it while we're here. So he had a new valve and he had a bypass done. And then he did okay for a few years, and then in 2009, he came back for an echo, and his ejection fraction, which is the amount of blood that's squeezed out every time the heart beats, was reduced. So it should be more than 55%, and his was down, it was 30 to 35%. So when we find that, you want to figure out why is the pump function reduced and what do we need to do next. So he had a catheterization through the arm up to the heart, injected the dye, and to look and make sure that all the blood supply was fine. And all his vein grafts were patent, so it wasn't that. The other problems that he developed some atrial arrhythmias. So this is the heart open, the right atrium, the tricuspid valve, the right ventricle, left atrium, mitral valve, left ventricle. This is your aortic valve and your aorta. So this man has already had a heart attack. He's already had his aortic valve replaced. Now he's developing problems with his atria. So the thinking is that with the radiation, they get fibrosis or hardening of the walls of the atria, which leads to electrical problems. So now he's developing atrial arrhythmias, and he's also starting to develop some problems with his valves. So he's got narrowing of his mitral valve, and he's got some regurgitation or leaking of his tricuspid valve. So he was sent for an evaluation for potential second valve surgery. And I believe at the point of that evaluation, which was at the Cleveland Clinic, they felt that he wasn't really bad enough that needed to be done yet, so he was just kind of medically managed for another few years. So when he came to the Brigham, he was complaining of slowly progressive, basically swelling of his abdomen and shortness of breath, and his exercise capacity had been decreasing. So here's his echo. So remember, this is the front of the chest, the right ventricle, the septum, the left ventricle, the left atrium, and your aorta. So in this one, you can see the left ventricle, it's contracting, but it's not as vigorous as it should be, so his function is reduced. And his mitral valve here doesn't look normal. See all this bright white stuff? That's calcium or thickening or hardening of the apparatus around the mitral valve. The leaflets you can still see flickering in and out here, and they look okay, but this thickening is very abnormal. And on this view, again, we're cutting the heart in short axis. So this is the left ventricle here, this is the mitral valve in the middle. We call this kind of the fish mouth view. The mitral valve leaflets are much thicker than they should be, and that valve should open nice and wide and close, and it's really not opening the way it should. This is the four-chamber view, again, left ventricle, mitral valve, left atrium. You can just almost appreciate how calcified and hard and thickened these leaflets are, which is certainly not normal. On this two-chamber view, we've put colour flow Doppler across. So I mentioned that briefly earlier. Colour flow Doppler basically, it's two colours, usually blue and red. Blue is away from the probe, red is towards the probe. This colour scheme over here, basically, the faster the blood is moving, the more the colour comes up towards this end of the scale. So any of this yellow flow here is a very fast flow. So the reason that blood flow is so fast is that this valve is narrowed or stenotic. So he has an issue with narrowing of this mitral valve. And so that's what we call a transthoracic echo. So to get better pictures of the heart, we do what's called a transesophageal echo. So we put a probe, which is kind of like a gastroscope. We put it through the mouth, down the esophagus, and the esophagus sits right behind the heart. So the ultrasound beam now goes this way. So we get really nice pictures of the left ventricle and the mitral valve and all the valves, really. The patient lies on their left side. They have a little bite block sitting in their mouth. The probe goes in. They're asleep. We give them some sedation. We numb the back of their throat. And then we take our pictures. And the TE probably takes 30 to 40 minutes. And we have some really great software now where we can get some really nice 3D images. So the orientation of a TE is slightly different than a transthoracic echo. So now the most anterior thing is the left atrium. So this is the left atrium up here, this is the left ventricle, and this is the mitral valve. So we were suspicious on the transthoracic that this mitral valve leaflet was abnormal. It was thickened, it was calcified, it's really kind of stuck, it's not moving very well. And you can see it over here as well. Basically that valve's just not open the way it should. And also the ventricle is not contracting as vigorously as it should. This is just a close-up of that valve again. You know, it's just, this should all be nice and thin, like down here. It should look like that. But it's all thickened and it's not moving and it's narrowed. And basically it's the radiation that's done that to this valve. This is a view from the stomach. We go down with the stomach and look at the heart from underneath. And so you can see, just to appreciate the calcium and the hardening around that valve. This is a view of the right side of the heart, the right ventricle and the tricuspid valve. So valve leaflets should be thin and pliable. They should open and close very nicely. This is what the mitral valve should look like, but you can see that it's clearly very abnormal. So these are some 3D pictures. We get some beautiful 3D imaging of the heart with echo as well. And what we're looking at here is what we call the surgeon's view, which is as if you have the chest open and you're the surgeon looking down on the valve. And so remember, this man had an aortic valve replacement. So this circle that you see here is the valve, the previous valve that had gone in there, and these are the leaflets opening and closing. And that's working fine. And then over here, this is a 3D of the mitral valve, which is thickened and not opening properly. And this one down here is imagine the mitral valve. You're the surgeon, you're in the OR, you have the chest open, you're looking down at the valve. This is basically what the surgeon sees. This is the anterior leaflet of the mitral valve, this is the posterior leaflet. And this black part in the middle is what we call the valve orifice, which should be much wider than that. But because it's thickened and narrowed, it's kind of like a slit. And you know, these images, compared to what you see when you're in the OR, it really very much looks like this. With the 3D software that we have, we're able to generate all sorts of cool 3D volumes and tell exactly what the volume of the left ventricle is, you know, what the perimeter of the valve is, what the valve orifice area is. We can work out all these numbers and tell the surgeon before the patient goes to the OR. And we can generate all these numbers, and we can even tell them what's the diameter of, you know, the valve is broken into these little things called scallops, and you can tell them what's the size of the scallops. And it's really amazing the information that we can give the surgeon before he even goes in there to open the chest, and it helps him to plan his surgery. So in this man, what he had was moderate stenosis or narrowing of the mitral valve. He had some mild leak of the same valve. He had some mild to moderate leak of the tricuspid valve, but his prosthetic aortic valve was working well, thankfully. So there are the two cases. Basically, the reason this has kind of become such a big area in cardiology is that patients who have cancer are living longer. So lymphoma patients are doing better, breast cancer patients are doing better. These patients get radiation and they get chemo, and then 20 to 30 years later they develop heart problems. So basically the European Association of Cardiovascular Imaging and the American Association of Echo and all these people have got together and come up with guidelines to just help us know how to approach these patients and when to image them. And I'm just going to talk really quickly about cardiac toxicity. It's one of the most concerning side effects of anti-cancer therapy. The gain in life expectancy obtained with this therapy can be compromised by increased morbidity and mortality associated with the cardiac complications. So, I mean, certainly when you're approaching a patient with lymphoma or breast cancer, you want to tell them, we're going to treat you aggressively and we're going to kill your cancer, basically. That's what they want to hear. In the past, when we didn't know the cardiac side effects, patients basically weren't told because we didn't know. Now we're having to tell them very early on, we're going to treat your cancer, we're going to cure you, but we may affect your heart. So the patients are coming to us much earlier in their chemo and their radiation for what we call cardioprotection, which is where we try and protect the heart muscle cells so that they don't get damaged. Radiosensitivity of the heart was recognized all the way back in the 60s, and now the heart is regarded as one of the most critical dose-limiting organs in radiation therapy. Basically, how toxic it is depends on the total dosage that the patient got, and then it's made worse if they get chemotherapy as well. And the manifestations may not show up until years later. So about 50% of cancer patients receive radiation. It does lead to a significant improvement in disease-specific and overall survival. And as I said, the complications were originally described back in the 60s. Skip over that. There are risk factors for the development of this, and they include basically if you're radiating the front of the chest, the high dose of radiation, younger patients tend to do worse, where the tumour is in relation to the heart, lack of shielding, not shielding the heart properly, whether if they're getting chemo as well, and then if they have other risk factors for heart disease, including diabetes, smoking, being overweight, high cholesterol. For Hodgkin's, which is what these patients had, basically what they used to give them was called mantle radiation. So they radiated the whole chest pretty much, and the heart's right there. So that's why the heart really gets affected by this radiation. And in fact, this was kind of an extended mantle radiation, because when you have lymphoma, you've got lymph nodes. They could be in your neck, they could be in your chest, they could be down here. So they want to make sure that they're covering all of those and that they're going to cure the patient. Hodgkin's is very curable. The overall 5-year survival is greater than 85%, and that's why they treat these patients so aggressively with radiation. And obviously there's a significant incidental exposure to the heart when they're giving them this radiation. So the relative risk for a Hodgkin's lymphoma patient of developing heart disease is more than 6. So they're more than 6 times more likely to develop heart disease from the radiation. Breast cancer patients, similarly, especially if it's left-sided breast cancer, have a much higher risk as well. They also develop ischemic heart disease, so coronary problems. They need valve surgery, pacemakers, heart failure, and cardiac death is much higher in these patients. This is a complicated slide, but basically it's a complex process. It starts with microvascular injury. They also get endothelial injury. They get a progressive decline in their function of their heart. So we measure echoes in these patients to make sure that their heart function is not changing as they're getting their treatment. They also get pressure and volume overload. And then if you throw in on top of that radiation, if you throw in chemo, which is also toxic to the heart muscle cells, it's really amazing that a lot of these patients do very well and don't get any heart complications, but certainly, quite a number of them do. Skip over that in the interest of time. So the calcification that I was mentioning earlier from the radiation, basically, see these white specks here? That's calcium. It's abnormal. So that should not be seen on your aorta. And the reason that the surgeons want to do a chest CT before they bring the patient to the OR is they're going to clamp this aorta when they put the patient on bypass. So they want to make sure that they're not putting their clamp on a piece of calcium that's going to rip the aorta. So they want to know exactly where the calcium is. As I said, they get valvular heart disease. I think these numbers are very interesting, that 10 years after radiation, 1% of these patients have valvular disease, but when you go out to 20 years after radiation, 6% of these patients have valvular problems. The ratio of these patients needing valve surgery is much higher than the general population. I just put this in at the end to show you all the different types of imaging that we can do for radiation-induced heart disease. First one there is echo. I've shown you some echoes. We've got cardiac MRI and CT, which are obviously great imaging modalities. Each one of these, I know the patients that I showed you kind of had all of them done. In the real world, they probably wouldn't have had all of those done, but at the Brigham, it was such a great place that these patients get everything done, and it's a great learning environment for people like me. But this man probably could have gone to the OR straight away after his echo, maybe his CT, but the MRI was nice additional information. He had a TE in the OR, but he didn't have one before he went to the OR. But basically, what this slide shows you is that each of these imaging modalities has different pros and cons, and it's really nice that where I trained I got to experience all of them, so I know the pros and cons of all of them. So if somebody says to me, I've got this patient with this, what imaging modality do you think you would recommend? Then I can say, well, I think if it's a young female, I would do an echo because there's no radiation, rather than doing a CT, which has high radiation. or an MRI has no radiation. So there are pros and cons of each of these, and it's really nice to have experienced all of them. And then I haven't even spoken about SPECT, which is nuclear perfusion, and that's another way that we have of checking if their blood supply is okay. So in conclusion, cardiovascular morbidity associated with radiation is increasing in prevalence because these patients are surviving longer. We know certain predisposing risk factors. Screening is advocated by the oncology and the cardiac communities, but there are lots of uncertainties around how to screen, when to screen, and what to do with the results. And I presented these cases when I was at the Brigham, and one of the attendings in the audience said, well, you know, this guy, the first guy who had the stress echo, you know, maybe he didn't even need a stress echo, and why was he being followed, and maybe these patients don't need this. But if he hadn't had a stress echo, they wouldn't have detected the mass probably for another few months when he started to get symptoms. So just to follow up on the two cases, the first patient was the large mass. He did very well and is doing well in follow-up. He's having echoes every so often to make sure that the myxoma doesn't come back, so they can come back. The second patient was managed medically. Surgery was deemed very high risk. He'd already had one previous surgery. He had some calcium of his aorta, and they kind of thought he was high risk to bring back to the OR. So he's being followed by the heart failure service. He'll probably need surgery at some point, but for right now, he's doing okay medically. Any questions? Yes.
I was wondering, you said that the MRI machines have like the big magnets in them. So how do they get them into the rooms?
So the patient, you have to screen the patient before they go in there. So the patient has to take off all their metal, and you can't have an MRI if you've had a pacemaker or if you have any metal in your body, basically. So if you have any, screws or plates or clips or anything like that, we have to screen every single patient before they go into the scanner. But once, if you went in there and you've no metal in your body, and you take off all your jewelry and you take out your phone and your coins and whatever, you're fine. You can walk into the room and you're fine. And the technologists work in that room every day, and there's no issue. The only issue is when you walk in there with metal.
And how do you get the machines in there? Because wouldn't you have to pass by?
They don't turn the magnet on until they put everything in, and then they turn the magnet on.
They're superconducting. They get charged with liquid helium.
Yeah.
And they're these superconducting magnets that have liquid helium in them. And so when that liquid helium is not there, it's just a coil. It wouldn't affect anything. Yeah. But when they are charged, they're extremely high powered. When I was at Notre Dame, they had a small bore MRI there. I don't know if you've ever seen one of those. They had stuck a frog in this small bore, and just the iron in the blood of this frog was enough to kind of levitate this frog in this small bore MRI. So sometimes they can have incredibly, like small amounts of diamagnetic material. But they're not just like magnets that you stick in your refrigerator.
Any other questions?
Oh, you were stretching?
What causes it? So in these patients, it was the radiation, but it can also happen with age. So if you scan older patients, you'll sometimes see some calcium. Basically, it's part of the atherosclerotic process. So they get, I don't know if you've done much about atherosclerosis, but you get these changes in the endothelium of the vessel, and then you get these kind of fibrofatty plaques building up, and you get macrophages coming in, and you get all these changes, and you basically get the formation of plaque or cholesterol, and you get a layer of this, and this happens in all of us. Some people it's worse, if you smoke, or if you have diabetes, or if you have high blood pressure, but it happens in everybody. And the plaque, in most people it's soft, but as you get older it can harden. It's just a part of the atherosclerotic process that the plaque can harden or get calcified as you get older. So if you scanned people in their 80s and 90s, you'd see a lot of hardening or calcium in their hearts, whereas if you scan a 20-year-old, you won't see any calcium. It's just a different part in the process of the atherosclerosis, but it's accelerated by the radiation. Yeah.
So when did you decide you wanted to be a doctor?
I think I was about 12. I don't remember. I just remember always wanting to be one, and I did well in school. did well in we do what's called the Leaving Cert exams at the end of high school. It's one big exam, so it's not a continuous assessment process. Basically, you work for 6 years towards this big final exam, and everything goes on that exam. And every student in the whole country takes the same exam. So you're comparing yourself. Everybody's doing the same exam, so you get results, and then you're ranked based on that, basically. And then it's a point system for getting into medical school. So we don't have to do any interviews or anything. It's all based on your academic score. But I think when I was about 15 or 16, I went to my GP and told him I wanted to do medicine. He was like, no, you don't want to do it. It's getting better. I mean, when he trained, he was doing 100 hours a week. When I trained, I was probably working maybe 80 hours a week. Now they brought in the European Working Time Directive, so interns and residents and fellows can't do any more than 24 hours at a time, which is better than it was 36 hours when I was there. And they're trying to limit it to 40 hours a week, and it's better, but it's still not the easiest job in the world. But looking back, certainly it's medical school was great, very interesting. Internship, I mean, I had a great time because you go from medical school to being an intern with all your classmates. You're in a class of people, 120 people, you're in that same class for 6 years. You know these people really well. And then you're all interns together and you're all working together, and you're finally grown up, you've got a job, you're making money, and you're young, so you can do the hours and it's fine. I think it gets harder when you get towards fellowship, because it's like everybody comes in at the bottom and everybody's the same, and then it's like a bottleneck. The further up you want to go and the different specialties you want to get into becomes super competitive and really hard. And then in addition to working all those hours, you also have to study for exams, you have to write papers, you have to get published. I didn't even talk about that, but that's a whole separate side of it. And it's just because, and we're all doing it to ourselves. We're all super competitive individuals. We've all achieved highly coming up the way, and because everybody is really good, and there's only so many places. Everybody thinks, oh, if I do this, I'll get a place ahead of somebody else. So we're all kind of making it harder on each other by being really good and working really hard. But the standards are very high because there's so few places. Like there was only 6 cardiology fellowship, actually 4 the year I did it, in the whole country. To get onto the cardiology fellowship the year I did it. And so it's super competitive. But even to get into medical school, I believe over here is super competitive. So I don't know. I think I certainly wouldn't change it. I'm delighted that I am where I am. Along the way, I've probably thought at some points, why am I doing this, or why did I do this? Because I've put my parents at multiple points, because I'm the only doctor in the family, have said more exams? Why? How could you possibly need to do more exams, or how are there more exams? Because they don't get it. But even now, all the time, and I work with 8 cardiologists at Main General, the more you know, the more you realize you don't know. And things are changing all the time, and there's new studies coming out, and there's new data, and you have to keep up to date, and what was recommended 5 years ago is no longer recommended, and so you constantly feel like, you almost feel like you don't know enough. Even though you know a lot, you constantly feel like you need to learn more, which is great. And I think it's one of the only jobs where you go in every day thinking, you need to learn more, even at this stage. Any other questions?
I have a lot of questions, but I'll just keep them kind of focused.
Mm-hmm.
First of all, in the United States, you go to medical school, graduate with the hope of a high-paying job so you can deal with enormous medical school student debt that you just finished with.
Yeah.
Is that the case here, or is it publicly funded?
It's publicly. So I went to medical school for free, basically. Yeah. It's publicly funded, paid for by. We have quite high taxes. The tax rate in Ireland is in the high 40%, and so it's paid for by the taxes, and then. The hope is that when you graduate, then you'll stay in the system and you'll pay high taxes and you'll pay it back. And so the problem with that, though, is that as you go through your training, you reach a certain point. Like I left because I had to leave. So every cardiologist in Ireland has to leave because it's so competitive. You come to the States, you go to either Brigham or Mass General or Cleveland Clinic, and you come here and you do a fellowship. Some people go back, and some people stay. And it's even now, it's super competitive. So there was one job last year for a non-invasive cardiologist in the whole of Ireland, and 18 people applied for it, who are all away, waiting to go back. So, it's not that, and some people in Ireland think, oh, we train these doctors and then they leave and they never come back. We leave because we have to leave. It's just part of the process. Most of us want to go back, but then it's also super competitive to get back because it's a public system. So the government pays for the salary of the attendings, and there's not enough attendings. Like, there's more cardiologists at the Brigham than there is in the whole of Ireland. So there's not enough cardiologists. But in order to make more jobs, the government has to spend more money. And right now, they're not allowed to spend any money on jobs.
So it's really the taxation system that's causing the bottleneck, because there is a demand and there is even the supply, but they're not able to meet the supply and the demand because they haven't figured out the economics of it. The private system is not recourse.
You can go back to the private system, but that's more difficult, and the private hospitals are not linked to universities, so then you don't get, there's no teaching, you don't get interns, residents, fellows, you don't get the interaction with the younger people that you need to keep up to date. So that's why most people don't go back to private jobs.
And what percentage of Ireland has private insurance?
About 30%. Yeah.
And then is that about 30% of the healthcare that's being provided is through the private?
It's probably less than that. Most patients go through a public system and only use their private insurance when they want something done quickly. So that's why the public system is always broke, because they're treating a lot of patients, even those who have health insurance, but they don't always use their health insurance. Because you're entitled, when you go into a public hospital, you're entitled to free care, even if you have health insurance. And you can choose when to use the health insurance, because it's separate.
So I have so many questions. But, how, first of all, from the physician's perspective, how could that problem be solved? How can you meet supply and demand pressures over there in Ireland?
Yeah.
And following that, with that sort of unique perspective from the public single-payer system that they have in Ireland, we are obviously currently in the midst of a radical upheaval in the medical payment scheme in this country. What is your perspective? I think we can unique insights there.
I think what should have happened is that between 2000 and 2008, when the country had a lot of money, there was a lot of money in Ireland in those 8 years, that the government should have invested in the healthcare system, which it didn't, which is a pity. So that's when they should have put money into jobs. And so instead now everything is contracting. They have to, wards are closing, nurses are leaving. They haven't employed any new physios or occupational therapists, or the numbers of staff, instead of growing as the population grows, are dropping because jobs are being lost and people are leaving. And then salaries have fallen as well. So it's far more attractive for a student nurse coming out of college to go to Australia or, America or Canada or wherever, where they're going to get paid more and be able to travel. I mean, they're only in their 20s, than to stay at home in Ireland and make, work hard and make bad money. As regards over here, it's hard in Ireland because it's a publicly funded system. Sometimes it's harder to get things for patients who really need them. So you kind of have to, break rules a little bit. So if you have a public patient who needs a procedure done and the wait time is like 6 months, sometimes the patients get so bad that they end up coming in through the emergency room and going and getting their procedure done that way, which costs more money. So in the long, that's not a fix. It's like they're putting Band-Aids on all the problems rather than trying to fix anything. And similar to over here, the government only lasts for 4 years, and then you have a new government in. So nobody's ever in there long enough to make the changes that need to be made. And obviously the governments want to be popular. They want to get re-elected, so they don't want to make unpopular choices. But then when I look at the system over here, where everything costs so much, and people have to have insurance, and Certainly, I don't know. There must be a way. I haven't found it yet, but some country must have a better health system. I think maybe the Scandinavians have it a little bit better than the rest of us, but they pay really high taxes.
In New Zealand for 3 years, I found it to be
Really?
very efficient
Yeah.
and excellent healthcare.
Yeah. Because I think there's a lot of waste in the healthcare system here, and there's a lot of expensive tests that are done that probably don't need to be done.
Yeah.
And patients pay a lot of money for all these tests, so it's
I think one indicator of the success of the public health care system is the extremity of income inequality in the country. Like, what's the income distribution in that country?
yeah.
New Zealand is pretty flat.
Okay.
And, which seems healthy.
Yeah.
There's like a strong middle class and not much on either end.
Right. Okay. Yeah. In Ireland, because it's such a social system, there's the middle class really is what's being squeezed at the minute because they're paying a lot of taxes. There's not that many very high earners. It's similar. You've a big middle class, and then the lower socioeconomic groups, they get a lot of state funding. They get a lot of stuff for free. Basically, they get they get benefits. They get free healthcare. They get free housing, money for food. They get a lot of things for free, and then they don't always appreciate that, and that because that group then, because of where they're living, they all smoke and they all drink, and then they use healthcare more, and it's kind of a vicious cycle. But it's Ireland, because we've gotten into the pattern of supporting these people. And there's really no incentive for them to work because they wouldn't make any more money if they were working than if they weren't working. Like they're getting a lot of money for not working. So it's hard to break that cycle. And kids that get born into those families look at their parents and say, "Well, mom and dad have never worked, and they get paid by somebody. So why should I work when I grow up?" So unfortunately, those cycles continue. Yeah.
Well, I'll ask one last question that probably easily get your test, but unless there's any other questions anyone have. Took you 19 years, and you kind of spoke to that a little bit, but can you speak specifically about how that affects like family choices, like when to start a family, how those choices.
So what's really struck me when I moved to the US was that people over here seem to have their kids much younger. In Ireland now, the average age for a woman to get married is 33, and to have their first child then is around 33, 34. Obviously there are the group of people who don't go to university and get jobs and live in the same area where they grew up, and those people have kids younger. But for anyone who goes to college or university or goes down the professional route, basically people don't have their kids until they're in their 30s. Certainly medical school, I don't think nobody in my medical class had any kids during medical school, which I know is different over here. And when the time came to choose between GP or medicine or surgery, family definitely comes into it then, hugely, because most people who go into GP then get married, have a lot of children, it's definitely an easier track. Those people who go into surgeries, mostly men go into surgery because they don't have to worry about having children. And cardiology is becoming more female, but it was previously a more male-dominated specialty. But absolutely, certainly, it's made it difficult. There's no way I probably could have, but there's no way I could have imagined myself having a kid in my 20s. And I really enjoyed my 20s. I had a great time. I was traveling and working and hanging out with my friends. It was great. But then certainly once you get married and you start, planning a family, it gets harder. And I was just saying earlier that, so when I had my daughter, who's 4 now, I was doing my USMLEs, which you guys have to do them as well, I think, for further on. But in Ireland, before you can come to work in America, you have to do 3 steps of your USMLEs. And so I did step 1 when I was pregnant when I did step 1, and then I did step 3. So I was 30 weeks pregnant, flew from Ireland to LA, to do a clinical exam for my USMLEs and a job interview for the Brigham. So I always tell my daughter that she came with me to do those things. But, that's not... And again, my mother was like, what are you doing? You're completely crazy getting on a flight at 30 weeks to do an exam and an interview. And, I did it. And I think medics, we just do it. You just do it because it's part of what you do. But certainly it's not as big a deal in Ireland because most people wait to their 30s to have kids anyway. But over here, I think that would be very unusual. I think most medical students have kids during their medical school. And I think it's more kind of integrated over here. But certainly it plays a role, particularly as a female. Yeah.
Is there anything else as a female cardiologist that you could say to the 90% female class of medical students here?
I don't think so. I think it's definitely gotten a lot better than it used to be. Like my class in medical school was probably 60% female. Subsequent years were 80% female, and then they changed the exam structure to try and get more men into medicine because it was going to be a big problem with all the women going off having children and taking part-time jobs. But I don't know. There are certain portions of medicine or areas or specialties where it's definitely more male dominated. So I would never have done surgery because, first of all, the hours, all the standing in the OR, I think I was a fainter back in college, so that never would have worked. But like a surgeon's life is very hard. Like bad and all is cardiology, it's surgery, no, there was no way I could have done that. And then on the other side of it, general practitioner, yes, a very nice lifestyle, and you can have as many children as you want, but a general practitioner has to go in and listen to people's problems all day with no break and very little support, and a lot of them feel very isolated. Whereas I work as part of a team. I've always worked as part of a team. There's always lots of people around. I work in a hospital. I have access to whatever tests I want. So there's pros and cons of everything. And I think the choices that you make are very individual. And that's the nice thing about medical school, is that there's so many different people in the class, and everybody finds a little niche area that they want to do, and everybody ends up, and there's so many different things you can do in medicine as well, from pathology to neurology to, you can even leave medicine. A couple of people have left and have gone into industry, and that's also a very good career.